Alysha. Alysha is part of, you can see, is with the Phillips family, with Patrick and them. But Alysha's been around for quite some time, but Alysha's worked in a doctor's office, and we're going to use her experience today on talking about some of the topics that we're going to be talking about today, and pulling from her knowledge base about what she's learned in the doctor's office, some of the issues that they face there. So, Alysha, it's good to have you here this afternoon with us.
Thanks for having me, Eric. I'm very passionate about this side of things, as you know, and just to clarify, I'm not Patrick's daughter. I am his niece, just to get that out there. But no, I'm excited to see what we've got in store for these folks.
Absolutely. So let's get right into it. So we're going to be talking about healthcare, the changes that are in healthcare. Now, Alysha, you and I know, and so does the rest of the team, we all know that we've been asked tons of questions. We've been asked about the Affordable Care Act, which we know as Obamacare, how that impacted medical billing, how it's still impacting medical billing. Let's discuss a little bit, the changes that we've already gone through to what we're going to now. So, back from whenever you were working at a doctor's office, I mean, certainly you were always faced with certain changes and challenges. So let's just discuss a little bit about some of the things that the doctors are really up against.
Changes are occurring all the time, and troubles with billing is something that it's definitely been a struggle. One of the questions that I get a lot of times too is going to a single payer. I don't know if you get that as frequent as about, but the single payer is something that we've had around, called Medicare too, and that's really where a lot of it comes into play. And from my experience, Medicare was definitely has a lot of points that you've got to follow to get that claim paid, and that's basically what it boils down to keep it to where these folks can understand. There's a lot of changes that go on, and you've got to try and keep the doctors informed so that you can file that claim correctly so it can get paid. And that's
exactly.
Difficult.
Well, what we're going to dive into first things first is let's see some of the things that the doctors are facing. Now, Alysha's already brought up the fact that one of the issues that we've all had to work and understand about is the single payer. Folks, I don't think we're going to a single payer as in a full single payer. We already have Medicare that's already working, so we're always going to have third-party payers, which is the insurance companies. The other thing was the initiation of the Affordable Care Act, or again what we know of as Obamacare. That's going. That hasn't changed. Matter of fact, that's helped some of our licensees increase their billing services, and I think that's what you're going to find today. And so, first of all, let's deal with some of the very current things that doctors are dealing with currently. Folks, you can see here as this is coming up on the screen. This is a very recent article that just came out. You can kind of see right up in this area right here. It shows that it came out Monday, October the 6th of this year. So we're just talking just the last few days here. Also, you can see where you can find this article. It's at ICD10.com, the full portion of that. But if you just type in 7 steps for helping physicians get ready for ICD-10, you're going to find this article. So, Alysha, let's talk a little bit about this article and what we found. First of all, this gal opens up here, Deborah Greider, she opens up most small to medium medical practices are struggling just to keep up with the changes taking place in healthcare today. All right, that got my attention, and that ought to get everybody's attention so far. Your target market, let's talk about what their target market is, Alysha.
Definitely. It says it right there in the first line, a small to medium medical practice. And that's exactly who you're targeting as your clients. And it's struggling just to keep up with the changes. That is, to say the least. Wouldn't you say, Eric?
Exactly. And if you're reading, I don't have to read this word for word, but you can see that she starts talking about larger hospital systems and small to large physicians' practices. And they're all having to move to ICD-10 implementation, so that's what we're going to be talking about today. If you do not know what ICD-10 stands for right now, by the end of the webinar, you will. So just be patient with us. We're going to explain exactly what we're talking about here. But I wanted to highlight this third paragraph here, as you can see. And it reads here, small physician practices are struggling with transition to electronic health records. Let's just stop there, Alysha. We're not even dealing with ICD-10s, but you get questions and I get questions. We all get questions. Don't doctors already have EHR?
Oh, all the time. Everybody's familiar with an EHR, and how do we go from ICD-10 to EHR? Well, we're going to show them how that ties in.
Exactly. So here's one of the issues. And yes, we're going to go ahead and answer the question. A lot of doctors already have an EHR, but what you're going to find out through some third-party research that we found, a lot of doctors aren't happy with their EHRs, giving you still another platform to go in there and help them. It goes on to say meaningful use. Again, that's another issue to deal with Medicare. But look at the other one, reductions in revenue and increased scrutiny by insurance carriers, including Medicare and Medicaid. Physicians have consistently struggled with managing patient care while also addressing all these administrative burdens. Isn't the focus of good medical care supposed to be the patient? You know, we don't have Patrick on here today, but I'm telling you, Patrick's been touting this information for years now. And again, here is someone else that's dealing with the issues. And folks, this is where you're going to be able to come into play. All these administrative burdens. Alysha, when you were in a doctor's office, I know you had to be dealing with these same issues.
Oh, definitely. You know, the ICD codes have been around since the beginning of claims being filed. That's how the physicians, you know, are getting money. And the concept and the idea of what we're trying to accomplish by going to a unified electronic record system is great in theory, but the transition for physicians is, I mean, they weren't even done with the problems they had before they've got all these other ones. And big, you know, reductions in revenue. I'm glad you pointed that out.
Yeah.
They can't afford to lose any more money.
Yeah, the more and more that we're all involved in what we do here at ABS, we get feedback from licensees who, again, once you become part of American Business Systems, you become what's called an ABS licensee, part of our big family here. And we hear from all of these folks from all over the country, and they are still finding doctors that are struggling with their EHRs, and more importantly, the reductions in their revenues. And it's just the doctors are struggling on top of all that now with all this administrative issues that they're having to come with. Now look at the another part of what she's saying here. Physicians are frustrated that the patient is no longer the sole center of attention. That's the issue. Doctors didn't go to school to become experts in all these administrative issues.
That's right, Eric, and not to mention, it's making physicians not be as centered around the patient as they should be. And on the back end, what does that do for the patient standpoint? They're not wanting to go back to see that physician.
You know, fortunately, my wife and I are able to take care of her mom and dad. And so my wife does take her mom and dad to the doctor quite often. And I cannot tell you the struggles that they have and that the doctors, they see it, you know, firsthand. And I get the reports back from them when they get back in the afternoons. That the doctor's frustrated because they can't get this information into their system, or they can't manage the care of their patients as they used to. We hear about this all the time. So as you can see here, this lady goes on. She goes, a physician goes to medical school to help patients and manage their care. And that's what's happening, is that the patients are now having to take a back seat to these other issues. Now, for everybody that's on the call today and that will listen to the call later on, please understand, you need to know what these doctors, where these pain points are for these doctors, because this is how you're going to be able to get your doctors once you become a licensee of ours, because these are the main issues that these doctors are dealing with. And she goes, no wonder why they're just hanging back and not spending any necessary time to get ready for ICD-10s. It's not their top priority.
That's right. And a lot of these points that you know, we're making here definitely associate with the physician and the fact that you realize that they realize they're under pressure, and they know that their patient care isn't what they want it to be. Put yourself, as you know, in their shoes and as a patient, and Yeah, take notes, folks.
Yeah, take notes here. And again, we've left this article up here long enough for you to write down that web address up there. But she goes on to say, by helping all of us to understand. So what are some key issues small practices need to focus on to get ready despite limited resources and staffing? Folks, let that sink in. Limited resources and staffing. Folks, if the doctor's revenue is declining, guess what he or she's having to do? Let go of staff and limit resources. So here you've got your key element. A lot of people ask us again, how am I going to get my first client? What am I going to do? How long is it going to take for me to get my first client? Folks, if you can just get this and let this sink in, and you can start talking about it now, you will find that you're going to have people come into you asking you for help. There is no doubt. Alysha, you want to say anything else about that before we go on?
No, that's a great article. I hope everyone did write down that course right there. Perfect.
Good.
I mean, it's exactly what we say.
We're going to talk about one more article. This one we found with Forbes magazine. This is an online article. This was dated September 11th, just last month. Article came out by John Goodman, and he's saying, why are doctors so unhappy? Top part of this article is saying that 6% of doctors are happy with their job. 6%!
Yeah. Unbelievable.
Are happy, according to one of the surveys that they found. And this survey, you're going to find out, is coming from a reputable survey. Goes on to say that doctors are committing suicide at a rate twice the rate of the general population. Folks, listen, the doctors are trying to deal with patients, deal with all of this, plus all the other things that they've got going on in their lives. They're people like you and me. And folks, whenever your cash flow starts to decline, this is one of the biggest things that starts to make people think, my goodness, no wonder I'm not so happy. Over half are unsure they would even recommend the practice of medicine to young people. So what's going on? So we're going to answer the question here. In this particular article, a doctor was interviewed here, and he goes on to say, granted, doctors are faced with kinds of stress other professionals are not likely to face. One doctor in residency wrote in the New York Times, there's a strange machismo, I got that right, that pervades medicine. Doctors, especially fledgling doctors like me, feel pressured to project intellectual, emotional, and physical prowess beyond what we truly possess. So,
very important point right there.
We always think that doctors think more because, again, look, they're in the white coats. They have a sense of authority. We think that they know everything. But look, he goes on to say, but these stresses have always been a part of medicine. What's new is the role of the third-party payers. So, again, let's let that sink in a moment. The doctor already says, look, we're already getting bombarded from intellectual issues, emotional, physical issues. That's always been a part of stress for medicine. But again, Alysha, we're talking about they're having issues with third-party payers.
They have to receive money. I mean, that's what it boils down to for them to stay in practice. And they can't keep up. How can they keep up with all the different rules going on with all these third-party payers and still try to keep up with, and that's just, Eric, I think something came to mind with that first part of that quote. I think there's a diagnosis code even with white coat syndrome.
There is. Yeah.
Okay, I thought so. Yeah, so it definitely stands true.
Well, let's look at the rest of this article here. This doctor keeps going on, and he says, while Medicare is essentially now requiring electronic medical records, the redundancy of myriad practitioners entering the same patient details is not only frustrating but costly because almost all independent practices cannot share or transfer information as simple as even patients' medications. Moreover, Medicare EMR requirements are specialty specific, thereby requiring me to record irrelevant information that I have never been trained to assess, yet alone treat. These requirements not only necessitate the hiring and training of additional employees, but also exposes me to legal liabilities. Why should you care? unhappy doctors make for unhappy patients, writes this doctor. So, okay, we could close the book on this whole webinar at this point, and you understand that doctors are having a big pain problem, and their pain problem is just simply getting paid. They're having to put in redundant information in their EMR systems. Alysha and I already know of doctors that see patients all day long, and then after hours, they're having to go retype all their information into EMR systems. I don't know how they're doing it, Alysha.
And Eric, I mean, we just discussed how with the decrease in revenue doctors have been seeing and having to let go of employees, and this one stating that to even try and keep up with all of the requirements and mandates, they're needing to hire somebody. So that's kind of a catch-22 in itself.
Correct. Now, folks, again, we've laid out the issues. What we're going to start doing now is sharing with you some of the solutions that you would be able to provide. And then we're going to come back again with even some more statistics of true third-party information that will help you as you go through this. So here's a doctor sitting back trying to figure out, okay, how am I going to solve these problems of ICD-10, let alone of this EHR, and my goodness, billing. My revenue stinks. I don't know how these doctors are going to do it. Alysha, you and I have even heard from doctors that are older doctors that are just going, look, just let me just put in the rest of my couple of years and I'm done, I'm walking away. Folks, we don't need that. And I'm talking about, we're talking personal here. You, me, Alysha, her children, my grandchildren, we don't need doctors walking away. We need good doctors, and we need good doctors to remain good doctors, not having to try to juggle and try to figure out all this information. Wouldn't you agree? I mean, Alysha, we're just talking just people to people here at this point.
Agree completely. I don't believe that doctors deserve, what they're having to go through right now. And I know the guys on the webinar today, billing might be a little bit, an explanation in itself, but what is ICD-10, Eric?
Yeah.
What is all this stuff?
Well, part of what we've already said, these aren't just the only problems. They're just the beginning of some of the problems. But as we're getting into this whole ICD-10, one of the biggest problems that are faced is that the doctors themselves, they don't understand it. Here they are. Imagine you, as a doctor, you've been practicing medicine for, 10, 15 years, maybe even 2 years at the most at that. And now they're having to switch what these ICD-10s are. Remember, this is a diagnosis code, and we're going to explain that here in just a moment. But basically, this is describing in a code format what's wrong with the particular patient. That's what they're dealing with. It's a code. It's a number that's associated with the problem of the patient, just in code format. And it's moving from a version 9 to a version 10. And we know that one code that the doctor has normally been using, let's just say for a sore throat, that one code could turn into 10 separate codes, all for the same thing, just a little bit more specific. That's the issues that we're having to deal with the codes here. So let's talk about.
I just wanted to throw in a little bit, why don't you tell them what the codes are used for? We understand these are diagnoses, but why do they need these codes?
Yeah, these codes, this is the only way that they're going to get paid, because these codes are used, because I know a lot of people ask us, well, I don't know about coding, and we're going to get to that in just a moment, but these codes are used to translate this information from what's wrong with the patient, what the doctor did for the patient, and those are those codes that you're going to see here as you do your billing. This is how the doctor is actually going to get paid by the insurance companies, because the insurance companies are not going to say, oh, you saw it for a sore throat. They don't. The computer systems are not looking for that. They're looking for a code. That's what they're looking for.
And it's universal through all insurance payers.
Exactly. So here we see ICD-10 is just the International Classification of Diseases. That's all it stands for. International Classification of Diseases. So it's the new sets of codes for reporting medical diagnosis and inpatient procedures. That's all it is. It's just a new version of what all this is. So why is this a big deal, Alysha?
this is a big deal because I think we've got an increase, just like you said with the sore throat example. You've got one diagnosis that we've been recognizing, and now we're going to go to 10 specific different codes for a sore throat. Now, that means the doctor has to code that correctly if he wants to get paid.
That's it, because no claim will be paid if it doesn't use the proper coding system. So, okay, so let's put all this in perspective here. Here we are. We just started October 2014. All of this is going to go into place come October 1st of 2015. So, folks, we've got about a year window of opportunity to help these doctors get into play. Really, I think after you and I were kind of talking about this, Alysha, earlier, we're really seeing that the window is really about 6 months here, because what we need to see are our licensees out there working with their doctors, just getting them prepared for all of this. If the doctor's waiting until October of next year, they're way behind the curve, and we're going to find a lot of doctors not even getting paid.
Oh my goodness, and what a headache if they are doing that. And the reason why they're waiting is because they haven't had the right solution presented in front of them.
Exactly. All right, so we've got a question that's coming in here exactly from someone about talking about their code. So let's deal with that. So why don't you take that question there, and let's see if we can both answer it.
If the codes are what make the doctor, if the codes are what help the doctor get paid, then how come we don't need to worry about them? Meaning, who provides these codes?
Excellent
Great
question. Let's see. All right, let's see, Rapali. I wish you. It's like you're reading our minds. This is our next slide to the presentation here. So we know that you're going to ask. Well, I'm not a coder, so where do we get these codes? Great question.
He goes on to say, just to add to that, how do we know if these codes are correct?
We're going to deal with that and show you that all together. Right. First of all, Alysha, where do the codes come from?
Eric, it sounds like you might have them all memorized.
Oh, yeah. That's right.
Well, the codes come from a really big database. I think they scanned each. No. Didn't you just say it's the international coding of diseases from Medicare?
Yeah, in actuality, folks, the codes come from the doctors. Remember
where are we getting the codes? I'm sorry. Yeah, so for a licensee and how they're filing the claim. Okay.
Yeah. Well, we're going to show you how they get them, but basically we get them. We're all going to get them from the doctor. So again, who's responsible for the codes in the first place? It's the doctors.
Yeah.
Yeah, they have to code them. That's why we showed that picture earlier about the doctor going, they're not going to know. And so what we're going to show you here in just a second, that you, even as becoming a brand new licensee, we're going to show you a very simple way through our system. Remember, because our system it's a web-based system. It's, as you're going to see here towards the end of the webinar, it's 100% integrated, and we're talking about everything. The patient portal, what the doctor does on the EMR side, what you do as the billing company, and the clearinghouse all works together. Now, folks, if you don't know what a clearinghouse is, last week we actually went through that in a little bit more detail on one of our other webinars, so be sure to get with your ABS rep on finding that particular webinar if you don't know what clearinghouse is. But folks, everything's integrated. So when the doctor is seeing the patient, just imagine this. This is where we're taking you. When the doctor is seeing the patient, the system will help generate the proper codes, whether we're in version 9 or whether we're in version 10. And then the doctor's going to get those codes to you so you can actually do their billing. It really is that simple. But it's part of us helping you be able to translate that information to your doctors so that we can help you get those doctors. That's what we're doing even today. So the codes, they do come from the doctor. We're going to explain this in the very simplest format as possible. Here we've got the old conventional paper claim form. What you see on your screen right there in that red portion of everything, just imagine that being in an electronic format, and you're just filling in the blanks. Am I correct about that, Alicia?
Yes, that takes me back. It's been years since I've seen that form right there, but definitely.
Yeah, basically what you're seeing there is a printed piece of paper where somebody physically typed all that out, and those little things slap and hit the paper there, and you see that there's information about the patient and what kind of insurance they're with and blah blah blah. But when you get down to the bottom part of it, you're going to start to see that there's that first thing called a diagnosis code. So look at that where it says ICD-9. This is supplied by the doctor, so a 213.00. Then there's another code, which is the procedure code. This is what the doctor has done for the patient. We're receiving that from the doctor. This is why you yourself you don't need to know anything about codes. So that's hopefully explaining. Now I'm going to go back to Rupali because you're asking us some questions. You said if the codes are changing from. Whoa. Hello.
What is that?
Y'all, everybody, hang on one second. All right. I don't know if we've got that corrected or not. We've got some response in the background. So if anybody is on our side, can you help us here? But Rupali's asking the question about if they're changing from 9s to 10s, then if the doctors don't know what the codes to provide them for their switch for billing so they can pass the same info to us, then how would we know if the codes are correct? Rupali, I'm going to show that to you here in just a second, so just hang on. I'll answer that question. Folks, we are having a little bit of technical difficulty here. I am not sure what's going on and why we're getting somebody feeding back through this. We're checking and making sure that everybody is muted here except for Alysha and me. Alysha, you still there?
Yes, and of course I'm even dialed in, so...
Yeah, I think we've got it under control. So
I think it's under control now, yeah, so you want me to reread that question? That was something else. I may have just heard a little bit there, but maybe it's a good time for us to all learn some sign language.
Okay, we do hear that in the background. So folks, just hang on with us just briefly.
Well, at least you know that this is a live presentation. We did not pre-record this. We are actually sitting here speaking with.
Okay, so what I've done here, I've muted everybody and then brought you back in. So I don't know if hopefully that took care of the problem. All right.
Do we need to see if everyone can hear us on that, or you?
I think we're all okay. So folks,
okay.
If you don't mind just raising your hands again. Okay, thank you, Tali. I appreciate it.
Okay, thanks, guys. Thanks for bearing with us.
Thank you for hanging in there with us. All right, so Rupali, we're going to answer your question. Hang in there. Thanks, everybody. Hands are going up all over the place. I appreciate it. Okay, so now let's talk about the ICD-9s versus the ICD-10s and how many it's switching over from where we are to where it's going. And actually, this graphic here is moving from 13,000 up to versus 68,000. And actually, I think we've even found out that, Alysha, it's even more than that is what we found out here. Would you say another 55,000 codes for the ICD-10s?
Oh, yes. I mean, we can just call it a million at this point. It's just a lot of codes to change over.
Folks, if you want a good laugh, just go Google funny ICD-10 codes. Just go out there and look up funny ICD-10 codes. You'll get a kick out of it. There's one code out there, patient set on fire by water skiing. No joke. It's out there. There's a code for that. It's hilarious.
Isn't there one where someone was hit with a duck?
Hit with a duck or run over by a turtle. It's some of the things are some of the most funniest things there.
And we're not kidding.
And we're not kidding. But there are true things, and so we're moving from the 9s to the 10s. There's an increase of amount of codes, which is going to give the doctors a huge challenge. Now, problem number 2 of what doctors are faced with is the implementation cost of the ICD-10s. And as you can see here, again, this source is from Nachimson Advisors LLC. So that's NACHIMSON Advisors LLC. So folks, they did this chart. We didn't do it, but you can see here that the typical small office, this is the 1 to 5 doctor practice, $2,400 in educations, $6,900 in the process and analysis, about $3,000 to change their super bill, $7,500 to do IT costs, $44,000 increased documentation costs, and about $20,000 of just simple cash flow disruption. Do you see that? $83,000 of what is going to impact a doctor's office already. We already know that they're losing money. We already know that they're challenged because of the electronic side of everything and the administrative side. Alysha, I don't know how these doctors are going to do it.
That calculates to be about $1 per code that they're going to lose with all the implementation versus the codes that they're having to increase, and that's a very powerful little chart there, because with what they're currently already losing, they're just sitting there exactly like that daughter. What do? I can't continue to practice.
Yeah. And again, not to lose, Rupali, in your questions, so how are we going to make sure that we get correct codes? I promise you, we're going to answer that question. That's the whole reason we're sharing all this information in the first place. So these doctors are asking you, can you help? They're looking towards us who talk about it on a daily basis. We all into somebody that's in healthcare. And so the question about it is, can you help? And I love this. Keep calm, because the answer is yes. That's where we want to get everybody to today, because that really kind of goes and answers your question. Yes, we do have an answer for that, and that's what we're going to show you right now. Okay, so we're going to kind of, Alysha, you and I are going to step through our iClaim system, our electronic medical record system, and show you, those that are on the call today, how truly easy it is for you to be able to do this for the doctors. Okay?
Let's do this. This is the exciting part.
Exactly. And let's tell everybody, folks, if you want to see this in live, a live demonstration, any of us will be happy to do that. So be sure, if you haven't been on here a long time and it's been a while since you've seen a demo, or you've never seen a demo of our system, we encourage you to do that, because it really puts this is where the rubber meets the road and everything. This is the solution that hopefully Rupali's looking for and everybody else is looking for that's on the call. So you log in through our website portal. Just go directly there. You're going to log in, and the first place you're going to land is on the iClaim portion of it right here. You can see right there, we're going to click on it right there where it says EHR. Boom. We just clicked on EHR, and this is going to bring us to the electronic medical record side of everything. And what we want to be able to do from here, we can set up a patient who is not a real patient, we can create Mickey Mouse there if we want to. But Alysha, this is where we can go in there and start doing what's called, get into their problem list. So I'm just going to kind of click through here, and if you want to kind of talk us through, kind of what we're doing at this point. So we're going to get into one of these patient records, and you can see here we're underneath this area, underneath objective, which is this O. But before I do that, Alysha, you want to explain what that SOAP stands for right there?
Sure. I'd like to start by explaining that the portion that we're seeing right now is what the physicians and their nurses are going to be in. This is not a portion of the system that you're going to be in. However, this is definitely the key to getting those codes. And SOAP notes, the arrows covering the P there, but all physicians and their staff are familiar with what SOAP notes are. It's for the subjective, objective, assessment, and then plan of care. Basically, the reason the patient's coming in to be seen, what is observed, what the doctor is doing to help the patient, and then what the treatment's going to be.
Yeah.
And all of these have certain rules and regulations that it's already in the system. The doctor does not have to do anything.
That's correct. So again, let's just say that the doctor's going through this just normally. the system's actually going to help the doctor code properly. And as you can see here, the doctor can click on, or you as a licensee, we can show you, what we're going to show you right now is how to map or see what's an ICD-9 code, and then what it's going to look like as an ICD-10 code. That's what we want to get to. That's where we're wanting to kind of show you. And literally what you can do, you can take the doctor's codes that they are using right now and start plugging those into here, and the system's actually going to tell you what the proper correct codes are going to be. So
do they call it a crosswalk, Eric?
Yeah, that's a good way to put it. So we're going to click on it where it says new problem, and as you can see here, we're going to just pull up a regular family practitioner or family practice. These are going to be the generic codes that they're going to be looking at. So we're going to be looking at this one that's the tibula fibula. We can see here that we're under ICD-9, and we're going to look at this 82382. We're going to click on that.
I wanted to also point out real quick, Eric, I thought that was an important part. You had typed in fracture.
Yes, thank you. Let's go back here. I typed in the word fracture right there, and we got all the ICD-9 codes for fractures. And again, we're looking at that 82382 fracture of a tibia or fibula right there, and we can see that populated right up here. And then these 4 codes right here are the new ICD-10 codes. Now, this is important for you because, first of all, you didn't know codes, but the system does. And so literally you can take the codes that the doctor normally uses and then show them how you can convert those to ICD-10 codes and get them prepared for that at a fraction of that $83,000 that we were showing you earlier.
This is monumental, guys. The system has the codes. It has the ICD-9 code. It gives you what is in place of it, meaning what will be paid by the insurance payer. And the doctor does not have to know a thing. The system has done it for you. You don't have to know a thing. It's just a monumental moment. Sorry, I'm very passionate about this portion. And it's all within the same application. I mean, I don't think there's anything else out there like this.
No, there's not. And folks, the reason that we're showing this to you, and we would love so much to be able to help you understand that, is that the system that we're utilizing here is a system that you're going to be able to use to, again, help the doctors get on track and get prepared so that they don't lose more revenue. That's the issue. So the question has come back in, so the doctor has access to the system before he sends anything to ABS, tell the doctor which codes to pick. Basically what you're able to do before the doctor even gets signed up, that you can utilize our system and help the doctor map these things out. We would be more than happy to help you with that and to demonstrate to the doctor. Alysha, real quickly, tell everyone about part of the support mechanism that we give our brand new licensees as we do these demos.
Which part of that? Of the support? We definitely want to, from A to Z, and let us do the demos for your doctor prospects. We're going to help you with demoing for the doctors. You don't even have to know the system to even get a client in the first place. And then we want to even take you through step by step on how to, basically we're educating you on how to educate the physicians, and we're looking to partner with folks who definitely want to utilize and work with us in helping these physicians.
Yeah, so there is it. I think you're seeing it here, so that's really good to see. All right, so let's move on because we have just, man, this hour is going by so fast here. So we've dealt with the ICD-9 codes here. That's what we're the 10s, going from the 9s to the 10s. So this is a great marketing tool for you to be able to do. But now let's talk about the doctor kind of starting to see this, going, okay, I can see how you can help me there with the ICD-10 codes. What about my EHR? I really hate it. And with that comes the part about the billing. It all blends together here. So I found another article, Alysha, that's just incredible here. Doctors unhappy with EHRs. And again, I put the website down there so folks can go find it. But this is coming from a survey from Medical Economics. And this was a survey of 1,000 physicians. This shows a widespread dissatisfaction related to the functionality and cost of the patient record system, with nearly, how many is that? 70% saying the investment isn't worth it. Alysha, again, we get asked this a lot. Don't doctors already have an EMR system?
Yes, and that's what I want to find, a doctor that already has one in place. That's easier because they're so dissatisfied. You have something to show them how to make their headache go away. And look what follows after that.
Yeah, go ahead.
I mean, about 45% of physicians believe patient care is actually worse. Actually worse. And that's from physicians. Again, folks, it's something that they have to do. There is no ifs, ands, or buts about it, and we need to help them do that as painlessly and profitably as possible.
Exactly. I mean, if we keep going on, 2/3 said they wouldn't purchase their EHR system again. Their own, the one that they have. They wouldn't even go with it. 43% of physicians say that these systems have resulted in significant financial losses. Listen, when you've got a doctor, and again, I know of one here locally in the DFW area who sees patients all day long, at the end of the day, spends another 2.5, 3 hours retyping all the information in, and then spends another entire day on the weekend making sure all of his notes are basically in there properly. I don't know how the doctor has time to eat, let alone see his wife or his children.
Mm-hmm, exactly. And if he has any patients in the hospital, I'm not sure what kind of a physician he is, but I had worked for an internal medicine physician, and yeah, there's a lot of time spent.
Yeah. So again, we're not going to bore you by reading all this information, but you can see again, this is coming from Medical Economics, the survey, and then in a 2013 analysis by the RAND Corporation, researchers said despite huge investments, cost savings are still elusive. So just because a doctor already has an EHR system, folks, that shouldn't even stop you. As Alysha said already, she would actually be looking for doctors that have already adopted an EMR system and then begin a conversation with them of what we can actually do with our EHR system. As you can see, our EHR system can actually help the doctor code properly now with the 9s, let alone what it's going to be able to help them do with the 10s without having to learn all those new codes over again.
It says it right there, Eric, the choice of systems that are neither interoperable or easy to use.
Exactly. Yeah. And so here's some for you analytic people out there who always want to know percentages and statistics. Here are some statistics. 67% of physicians say that system functionality influences their decision to purchase or switch systems. We're talking out of that 1,000 doctors, 670 physicians says that the functionality influences their decision to purchase or to switch systems. This is where we help you. This is a lot of people ask, well, how are you going to help me get a client? Folks, this is what we do for a living. We work with you to help you get your clients. We will demonstrate to the doctor with you on the phone on a go-to meeting and show them the functionality of our system, and that is what's helping our licensees get clients. 48% said that cost is influencing to purchase or to switch. We can show in a demonstration that just by what we're doing, we can show those doctors that they're not going to have to spend any more than what they've already spent. A lot of times we can wrap up the whole cost of everything and just doing their percentages alone. But look at this. Nearly half of those doctors spent more than $100,000 on an EHR system. Alysha, that's almost criminal.
It is almost criminal. But you know what, Eric? I know doctors that would definitely spend thousands more to get a system that would do what the iClaim EMRx does.
Exactly. So again, folks, if you haven't seen it, feel free to call us up and we will certainly demonstrate that to you. Now, again, here's another source for you to look at, Black Book Rankings. We're going to show you a couple of slides here that have to do with some statistics. And here's one. Alysha, why don't you take this one?
Oh, okay. Well, we've got some statistics here. 21% are considering an upgrade of their RCM software within the 6 to 12 months. I believe you just said that. But, Eric, what is an RCM?
Revenue cycle management software. That's everything that we're talking about here.
Okay. So I guess our licensees would be something like revenue cycle managers.
Oh, yeah, that's a good one.
Okay. 88% expect a current RCM system upgrade within 6 months. What this is saying, folks, an RCM system upgrade. Would you classify iClaim EMRx as an RCM system?
Exactly. We're about to demonstrate the whole process for you in just a couple more slides here. And again, folks, look at this. This is 2014. This is a third-party market analysis that's been done. That coupled with what the doctors are having to do with the ICD-10 changeover, folks, this is, Patrick's talked about this many times. You know, when change occurs, disruption in the market occurs, this is where entrepreneurs can make the best and the biggest impact, not only for the people that they serve, but for you also. So, folks, again, we're not trying to do any more than to show you, like with a proof of concept here, these are the things that are going on, and this ought to help you answer your questions about, is this a good market to be in? Now, before she reads this one, I want you to understand that when we're talking about small physician practices, we're talking about a group of doctors from 1 to 5. So 1 to 5 doctors. Isn't that a sweet market to the sweet spot of a market for you to go after? How many of those are looking for a new? You read it, Alysha. Go.
Well, first of all, you know, folks, it'd be nice if we could do a survey, but if you think about your physician, I bet the majority of folks on the webinar today see a physician who's not in a group any bigger than that. Yeah. But 42% of those practices with employed billing staff hope to outsource their billing in this next year, in the next 12 months. Now, again, that's from 2014. So you see our little windows there where you see Eric and I. Those are slowly getting smaller as time goes on for your window of opportunity to help these physicians. And 42%, nearly half of those practices who already have employed billing staff, okay? That's something else, you know, get with your ABS rep and talk about that. But we'll be hoping, they hope to outsource, meaning they're struggling.
They are struggling. We put it like this, Alysha, once before in another webinar. If a doctor's doing seeing their patients, like they're hopefully that's what they're supposed to be doing, and that they have employed people to do their billing in-house, it is like they're running two separate businesses.
That's right.
And folks, a doctor doesn't employ a CPA to run his accounting. He outsources that, or she outsources that out to somebody else. And that's what medical billing has become, or revenue cycle management has become. That's why doctors are looking and hoping to outsource their billing over the next 12 months. 42% of them. That's at least 1 out of every 2 doctors that you'll ever come across. Now, when you go out to start to market, you're going to find out, man, there's not 42% of these doctors that are out here. That's why we tell you to wait and not try to go pre-market anything before you come to our class, because we don't want you to go out there and get, you know, the no answer right now because you just don't know what to say. It might not be enough, and then you wouldn't have us to support you on that back end to actually do some demonstrations for you. So again, all we're doing is trying to share with you that it's all going, that the system that we have in place all works together. So again, Alysha, there's 4 main components to our system here. Let's talk about them.
Sure. Real quick, and to that point, I mean, think about the statistics we put up on the physicians who are dissatisfied with their current software. You need the access to what we have in the training so that you can, you know, they're going to say no right off the bat. They're currently in pain with theirs. And we've got 4 components, as you see here. The iClaim, which, of course, is the billing side. You've got your EMRx, the electronic medical records. The clearinghouse, which you can learn more about that later, very important part to getting paid. And then we've got a patient portal. amazing. The patient portal, I mean, from a patient standpoint and a physician standpoint, it should have been here years ago.
Oh, man, absolutely. And again, if most doctors don't have this system in place, guess what they're having to do? They've got one piece, let's just say the practice management system. Just let's erase the name iClaim. Let's say that that's by some other piece of software. And then they have to plug in another EMR, or electronic medical records. Then they have to make those two work together. Folks, what you're going to see here in just a moment is ours is all integrated. There is no third-party practice management system tied to a third-party electronic medical records platform, tied to a third-party clearinghouse, tied to a third-party patient portal. Everything that we have here is all integrated. It's all together, and it works seamlessly. Let's demonstrate that to you. The patient at home can literally, through their portal, go in there and add all of their patient records, all of their patient information. I don't think any of us, when we're sick, just really enjoys going to the doctor and getting that little clipboard and then filling out everything and then going, oh man, they asked me about that question, I don't know about that, and then having to leave it blank or whatever. All of this can be done at home. Plus, I love this, Alysha. It's like, you know, you can pre-check in like you go to an airline. You can pre-check in from home.
Yeah, I don't know if any of the folks have ever been to something like a Care Now, those emergency care centers. You know, anyhow, being able to check in online, and also you're not under that pressure. That white coat syndrome is true, and so you just forget everything when you're at the facility. Do it when you're home. You have all the names of the medications. You know, Diane has also asked a question. I think I may have missed it, but she wants to know how long does it take to process the codes, the portion that we just went through. I thought maybe we could run through that just real quick, address that as you're going through this.
Let's do it while we're doing this, because Diane will answer that. We'll answer that question here. All right. So let's say the patient inputs all that information at home. All that information goes down to the doctor's platform, which is the EMRx platform. It's already all there. So it's going to help expedite the doctor seeing you and as the patient, and it's going to give such better care and really customer service back in the doctor's control to what he or she needs to do. Now, through this, Diane, to kind of help answer your question as how long does it take to process these codes, as the doctor is seeing the patient, the codes will be populated there for the doctor to grab and input and put into the system. So basically, it's instantaneously. Everything's in real time, Diana. Everything that we're showing you is in real time. What the patient does at home goes directly into the EMR system. Once the doctor gets through with that, Alysha, it goes over to?
It goes over to our iClaim side, the billing, the practice management side is the billing side. This is going to be something that the licensees are going to be in. We've been talking a lot about the EMR side, and just like the doctor has seen the codes pop up in the system on the EMR side, of course it's going to mirror on this side of it into the iClaim side. And Eric, I know your favorite portion of this is the claim status dashboard. I'm not sure if you're going to talk too much about that, but it doesn't get more real time than this system right here.
Yeah, and again, that's something we can certainly demo on a separate thing here. But folks, what you're seeing here, what Alysha just said, that the billing, and you can see based in there, here are those four components. Patient, their billing, inside of the billing is the clearinghouse. This is the entire system right here. Nice, neat, clean. Once the doctor gets through seeing the patient, it automatically goes to your side as the billing company. You're able to grab it, process it. It runs through the clearinghouse, and guess what? At the end, when you say generate claim, folks, that's going directly to the insurance companies right then. We're seeing doctors getting paid within 7 to 14 days of seeing the patient. Alysha, what is the normal average length of a doctor getting paid from the time that they saw the patient to the time that they actually get paid?
45 to 90 days, from my experience, if not longer, depending on how it's being filed, and depending on if the gals are keeping up with it. There's so many things that go into play. with the troubles these doctors are facing. And to have this, I mean, this is the aha. I mean, doctors are ready to go after they see a demo. It's a no-brainer.
Yeah. So again, let all this absorb of what we're showing you. We've just kind of review real quickly. What we did here in the very beginning of the webinar, and we're just coming up to the top of the hour, we shared with you what the big pain problems are. A lot of these issues are going to be solved by just simply the platform of which you have at your fingertips as a licensee. So again, we're going to leave that up there just for a few more minutes because I think the next thing that we have basically is just answering some questions. So Rich has got a great question that comes in here. He's asking the question, why does not mass email physicians for their business? Rich, we've actually had some success with that. I think one of our licensees by the name of Benny Biordi actually did that, and whenever he was on our last interview with him, I believe, Alysha, he said that he got 1 or 2 more doctors out of that.
Yes, I like Rich's thought process. I was going to say, definitely, Rich, you should see a demo of the software if you have not. All you folks need to be contacting your reps after this to see a demo so it can all kind of play together. And even Carol's question is great. I'm sorry that we didn't already address this, but does ABS medical record system meet the requirements of the Affordable Care Act and the HIPAA law requirements? That's that meaningful use. Eric, and does our system, does it meet all of those meaningful use requirements? It
does, and Carol, a great question because, again, the HIPAA issue, which is the Patient Portability Act, if everybody understands that, it's just the health information of everything that's going through that. So, yes, it does meet all the requirements. It has to because, again, we wouldn't be able to operate otherwise. We just wouldn't be able to do that. All right, let's see.
Got one here from Nabil. It says 47% who are likely to shift can merge with large groups, and small practices will further shrink. So do you understand the question? Okay.
Yeah, I think I do. Nabil's asking a question about, a lot of the doctors, or a lot of these doctors are merging with larger groups, or some of the larger groups are merging in with hospitals, and we have addressed that. There are articles out there that certainly talk about doctors moving from a single practice just simply because they can't make it, so they get absorbed by a hospital. And we already know that is occurring. But on the flip side of it, we've got doctors that are leaving that because now they just become basically employees. They're no longer independent practitioners. And they're leaving that, going back into private practice. And we heard of a licensee working with one of those types of doctors just here within the last 2 weeks. And guess what, Nabil? Whenever a doctor moves from these hospitals or these larger practices, all the patients that they brought over stay with that institution. So when the doctor goes back into private practice, that doctor has to start all over again. So the appeal of that happening, that used to be such a great appeal, the doctors are understanding that, and so the appeal to go into these larger groups or these smaller practices being absorbed by hospitals, that's no longer an appeal.
No, guys, it's all about the doctors were not informed correctly. They were word of mouth hearing this. It's all about educating the physicians with the right facts, and that's what we have. We've got the facts. We've shown you the quotes today. This is real. You've got to be able to show the physicians that and help them before they're forced to do something like that. They don't want to join a group.
Exactly. Well, folks, we are just a little bit over the hour. We're going to wrap it up here, so just give us a few more minutes here. We do want to talk about Patrick's money-back guarantee. This is in writing as you see it, just like it is on the purchase agreement. So if you haven't seen the purchase agreement, for those that have been looking and getting into this business, we have 2 classes left. We're going to share with you about the 2 classes that we have left. But if at the end of training, and basically we've got to change that because we've actually made it at the end, during any time of the training, you feel like what we've shared with you on any of our webinars, any of the business information that we've shared with you, if you feel like this is just not for you, after you fill out the purchase agreement and you've placed all of your money at risk, if you feel like this is not for you, just simply tell any of the ABS staff, and we'll be happy to arrange for a full refund of your entire licensing fee. And as Patrick would say, basically the only thing you'd be out at that point is a little bit of your time, a little bit of travel and hotel, just to find out that this may or may not be the right business for you. So that's our guarantee. That's the best thing that we can do, because again, we understand that you're talking to us over a telephone, you're seeing us over a webinar, and the best thing, part of your due diligence, is always to get here to training, and that's his word-for-word guarantee. Folks, if you want to know more about us, you can keep up with us. We do have a YouTube channel, so check us out at youtube.com/YABS. For those that are a little bit more tech savvy, you like to use the Twitter, you can find it and keep up with our blog through @ABSystems, through our Twitter account. And let's talk about that next training. That's just just a few more weeks away, Alysha.
That's right. And I thought we had reached our max. I know we're getting close. It's filling up pretty fast, and it's not far away. And look at that class. I remember it's good to see these folks' faces, down the line, and when you work with them for so long. But yeah, so November 3rd through the 7th. It's 5 days. November
5 days
3rd.
of live training. You'll enjoy all this. You're going to get your hands dirty into the claims, or whatever you want to say it. Lots of information. We only have 2 classes. This one and the December class. There's nothing here in October, and I can't believe we are 2.5 months away from the end of this year. It's unbelievable.
2015 is key for the doctors, too. They know that year, 2015.
Boy, don't they ever. Folks, we also want to kind of wrap up here, letting you know about next week's. And we can't stress this enough. If you really want to know where the rubber meets the road, come back and join us next Wednesday, October the 22nd. Patrick will be back with us. He's going to interview Corey Craig. Corey's been around for a long time. She's got some great information. I've just clicked on a link that's in your chat box already for you to go ahead and register for next Wednesday's webinar. Alysha, you have any other further little tidbits for us as we kind of wrap this up?
No, I think I could ramble on all day. Give me a call, guys, if you want to do that. But, Eric, I do thank you for allowing me to join you today. Guys, don't miss Corey. She is wonderful, fantastic, great story, and she definitely knows what she's doing. And all of those who did not get their questions answered, we do apologize, especially for the interruption earlier. And just